Greetings, Graham Warren, working with you on the hip hop case. So I'd like to walk through, the essence of this. This is a workflow, surgical workflow for hip and knee replacements. It is quite the elderly statesman now, but I think it's got many interesting learning opportunities. It's co-written with Judy Katie Ray and Dr. Paul Kanoja, director of orthopedic surgery at Hopkins. So these hip and knee replacements are going to be treated essentially identically. We don't distinguish between them. This case is an opportunity to experiment with an AnyLogic simulation model for a network of cues, one where you have multiple activities. And I'll lay that out in just a second. Hip replacements, these are used with permission. And here's a knee replacement. There's some demographics, patient demographics. These were collected by Paul Kanoja and published. And there is a reference for that in the reference list if you're interested in pursuing that further. I'd say this, the case is getting on a little bit. And so it's more than conceivable that you may be able to find some published literature that will show improved times, surgical times, and anything that is supportable using published literature, maybe your own personal experience, all that would be valid, and you can advance that in your solutions. All right, so one of the things that Paul Kanoja's paper, Paul and his co-authors in 2019 looked to basically show was that these surgical times are affected by BMI, and they use these different BMI categories: underweight, normal weight, overweight, obese, morbidly obese. And then they show that there's, that these categories drive the median surgical time. So you can see it obviously increases. Quite a number of surgeons were involved in the study, and looks to be in the ballpark of what 6,000 surgeries that actually were factored in this. Notice that very few underweight people are getting either surgery, but the other categories seem to have sufficient data. So less than 1% of the cases were underweight. And this is in contrast to the ASA physical status used by the American Society of Anesthesiologists, which does not show a significant relationship between ASA physical status and the length of the surgery. All right, so there's additional breakouts here by gender and race and so forth. And there are differences certainly in obesity and hence surgical times for these different categories. So what is this surgical process in a nutshell? So basically, you've got patients coming in. They've previously seen a surgeon, so they're coming in for scheduled surgery, and they will go through a registration process, after which they're anesthetized. They are then, have their surgery, and then they go through recovery. While they're going through recovery, the operating room is prepared for the next surgery, so there's a cleaning process. So that's the process in a nutshell. We've got some process times here. Now, these are actually stated as means. In Paul's study, they were medians, but we're basically just borrowing that as the mean. So these are crafted statistics. These are fictional because of that slippage from median to mean. And then we've created these standard deviations. So notice that not only is the mean time increasing, but the surgical time is increasing in variance as the BMI category increases. And you can see that more than 50% of the total cases are for obese, morbidly obese patients. All right, so here is an outline of what's entailed outside of the surgery itself. So we have the registration process. It's a mean of 15, standard deviation of 2. Pre-op prep, mean of 20, standard deviation of 2. Anesthesia, evaluation, and consent, 5 and 5. And then the procedure here is a weighted weighted mean and standard deviation based on these fractions here, and the stated mean and standard deviation for each for all categories, basically. And then finally, you've got this room turnover, cleanup, setup. Recovery is given here as well. It's actually not going to appear in our simulation. I'll explain that when we hit the model. And then the discharge, it also has, some of the folks go home same day, and there's a short discharge process if they do go home. Some folks go to the hospital for the night, but most go home. It's an outpatient, primarily outpatient workflow. All right, so in the subsequent videos, we're going to look at this workflow after we introduce the base case in the simulation model. Simulation model is pre-built. You don't have to build your own. The 4 lenses are: there's utilization matter, there's pooling matter, there's variance hurt, psychology matter. These lenses were introduced in the queuing module, but we're going to use those actually to sort of explore this model in a first cut. And so there's some questions here that the director of surgery is interested in. So you're writing to Paul Kanogia particularly, and he's interested in, how do you see this process? Is it a job shop, a bad shop? How does it look to you? And then what's the average patient flow time before and after? Where are the bottlenecks? And then are any of these proposed changes that you're offering, are they in conflict with DEI concerns? All right, now, at the time the case was written, this was actually, I think Paul expressed this in 2023, said that he does not believe that robotics will meaningfully reduce procedure times, but that's a few years ago. Things have moved along. So if you're of the opinion that robotics can meaningfully improve this process, you could recommend that. And any process innovations that have sort of come along and are published in the literature, you're welcome to take those up and include those in your solution. All right, so there's the AnyLogic model, and then there's the how-to video playlist, which you're looking at right now. And this is the intro. So let's jump right into the model in the next clip.